everybody. Thanks so much for joining us today. My name is Nicole Lamberson. I was trained as a physician assistant, and I volunteer doing outreach for our film, Medicating Normal, and I host conversations like this one today. Our guest today is Dr. Donovan Maust. He is a geriatric psychiatrist and health services researcher at the University of Michigan Medical School and the Center for Clinical Management Research of the VA Ann Arbor healthcare system. His research focuses on understanding determinants and outcomes of potentially inappropriate psychotropic prescribing to older adults with a particular interest in benzodiazepines and antipsychotics. Another area of interest is understanding how caregivers of persons living with dementia shape how those with dementia interact with the healthcare system. He does his clinical work. Let's see. Sorry, I lost my space. He does his clinical work on the consult-liaison and inpatient psychiatry services at VA Ann Arbor. He earned his medical degree from Johns Hopkins University and completed his training in psychiatry and geriatric psychiatry at the University of Pennsylvania. So welcome, Dr. Maust. Thank you so much for coming on and talking to us today.
Sure thing. Thanks for having me.
Yeah. So first, I guess, can you tell people a little bit about what you do and really how you became particularly interested in benzodiazepines and antipsychotics, specifically in older adults and those with dementia?
Yeah. So I, during medical school, did a sort of a summer elective focused on working with older adults and got really kind of fascinated about the public health implications of this large aging population of baby boomers in particular in the US, and sort of thinking about how the healthcare system was going to help provide care to the older folks. So in med school, really got interested in the older adults part first, and then had a really hard time actually deciding between medicine and psychiatry and neurology, but just ended up thinking that psychiatry and mental illnesses were sort of the most interesting to me. And it felt like over the course of my career, there might be kind of the most that we would learn and the most kind of exciting developments in psychiatry. So then when I did my residency at the University of Pennsylvania, and I was in kind of a research program or research track of my residency, and started working with a geriatric psychiatrist. And he had a project where basically in the state of Pennsylvania, the lottery helps fund a prescription assistance program for low-income older adults. And so essentially, I think the state started to kind of wonder about, they noticed that a bunch of older adults were being prescribed various psych meds. And so the state, I think, was kind of curious how or why these meds were being prescribed. And my mentor at Penn at the time, Dave Oslin, ran this kind of telephone-based service that essentially was sort of a tool to help primary care providers figure out what to do with patients who had either mental health or substance use disorders. It's all telephone-based. And so basically it would help decide whether or not these patients need to be referred into specialty care or could be managed in primary care. And so long story short, the state of Pennsylvania contracted with Dr. Oslin to have this telephone-based service for these older adults who had been prescribed new psychotropic medication. And so essentially a young, friendly behavioral health technician would call somebody who had received a new psychotropic prescription and basically talk to them and go through a number of kind of screening tools that we use to figure out, does this person have depression? Do they have anxiety? Are they having trouble sleep? To figure out kind of like what's going on and why are these folks being prescribed these meds? And basically, long story short, we were really very surprised at how low the symptom burden of these older adults was. So you have like on average folks who are like 80 years old getting prescribed new psych meds, and on kind of all of the different scales, again, for sleep, anxiety, depression, essentially like half of them hardly had any kind of symptoms at all. And looking specifically at the antidepressants, I think something like maybe 10% had this, using this thing called the PHQ-9, which is a scale for symptoms of depression. Basically, I think I should have looked at the paper, I apologize, but something like maybe 10% had above the level where you would think somebody had major depression. And the majority of people had really a very, very low level of symptoms. I kind of jokingly say it's like me on a Monday morning before I've had coffee, like not something that would really indicate that this person has major depressive disorder. And so for me, as in psychiatry residency, learning all about how to prescribe these medications and use these medications, it was really eye-opening for two reasons. First, it was kind of my first realization that the vast majority of psych meds are not actually prescribed by psychiatrists because there just aren't enough psychiatrists to see everybody. So most of the clinicians prescribing these meds, the majority of patients are actually primary care providers or non-psychiatric specialists. And then the other point was just this idea that like, so a lot of the prescribing actually seems to be to people who don't necessarily have what I as a psychiatrist would consider to be like a mental health disorder, you know, with a capital D. And so that was really very eye-opening for me as a resident. And then sort of here we are, what, like almost 15 years later. And it's been a big focus of my work and my interest.
Wow. Okay. So I guess, I mean, you kind of answered this next question in that question, but I guess it's sort of, since that was such a long time ago, I guess, what are the trends in antipsychotic and benzodiazepine prescribing to older adults? Is it still the same as it was then? Are they being, majorly overprescribed, and for conditions that aren't really, diagnosable psychiatric disorders? And if so, what are the outcomes that you're seeing from those trends?
Yeah, so I think maybe the really important thing to say first is really for all of these medications, there's this dual problem. Like, I absolutely believe that there are people for whom these medications are appropriate. On the other hand, there are people for whom they are not appropriate. And so it's this really challenging issue of like finding the right sweet spot and not having the pendulum go too far in either direction. And I think it makes it really challenging in terms of sort of policy interventions, again, to think about the sweet spot of what's the right amount of prescribing and how can you really define that and get at that. And so that, just want to make that disclaimer first. On the benzo front, it's been pretty interesting. So in general, use among older adults has been relatively stable. So one of the maybe most recent papers to look at this, they looked at about a 20-year period of time, not quite 20 years, it was from 1996 to 2013. And when they looked specifically at benzo prescribing to older adults, it was pretty flat. And in work that I've done in the VA specifically, actually prescribing to older veterans has been coming down. And in Medicare, maybe it's coming down. It's definitely not going up. So that's good from my perspective. What is less good is use among middle-aged adults. So like in that same paper that looked from 1996 to 2013, when they look specifically at middle-aged adults, which I think they defined as maybe like 45-ish to 64 or so, use went up like significantly over about the 20-year period of time. And not only was it the prevalence of use, or like the percentage of the population who over the past year reported benzo use, so that went up. What also went up though was the size of the supply. So like, for example, I don't know, if it essentially meaning like the milligrams dispensed per person went up over that period of time, which is concerning because we know for benzos in general, it seems like there's a dose response risk between the risk of harms, overdose or fall-related injury seem to go up as the dose goes up. So the fact that not only were more people getting benzos, but kind of the amount of benzo out there per person had also gone up is not the direction that you'd want it to go in. And so, while use among older adults being flat over time is good, even if I could like snap my fingers and have it go to zero, there's this group of middle-aged adults who are getting prescribed benzos who are aging in to older adulthood on their benzo, which means kind of like it's a problem that continues replenishing itself and is not going to go away. On the antipsychotic front, so in general, the concern and issue with antipsychotics and older adults is really specifically the population of older adults with dementia, where there's the biggest concern related to antipsychotic use. It's an incredibly challenging situation where the types of behaviors that prompt the use of these medications are really, really difficult for family members and for clinicians to manage. And so there are not great medication options out there for behaviors. Of the evidence that is available, antipsychotics actually have the best evidence for potentially being helpful. Again, it's an issue. It's a issue of like what's the sweet spot and getting to like what's the right amount of use. And for some patients, I would argue it is probably the right thing to do, but certainly not for all patients. So there's been a big concerted effort in nursing home settings, and use has definitely gone down over time, which again, overall is probably good, but then again, there's concern that maybe there are some patients who would really actually benefit from these medications who are not getting them. And so again, it's that issue of like, what's the sweet spot and how do we get it? How do we measure it?
So just a quick question to follow up on your benzo information you just provided. The study where you were saying they were getting higher amounts, does that mean that the doses were higher, or could it have meant that they were even staying on them for longer periods of time?
So that's a great question. So that's basically a nationally representative survey where, as part of the survey, they actually like look at people's pill bottles and they are able to get their pharmacy records like over a past year. So they would like literally look at like person A had this many prescriptions for lorazepam of this many milligrams a day. So they were essentially looking at like in the year among people who reported using a benzo, how many fills did they have and what was the dosage of their fills? And then they come up with like a sort of benzo unit per person per year kind of a measure, if that hopefully answers your question.
Yeah. And then also on the part where you said that, the oldest population, the benzo use seemed to stay pretty even and steady. Is there any indication though for somebody that old to be given benzodiazepines? I mean, they're on the Beers list, right? Which you can tell us a little bit about.
Yeah, that's a great question. So basically there's this thing called the American Geriatric Society Beers criteria, and they basically have, again, in recognition of this idea that in particular for older adults, there are some medications that pose some safety risks. Some of them, it's like for everybody, this medication is potentially inappropriate, or it might be like certain combinations of medications, or if you have a particular medical condition, then this particular class of medication isn't appropriate. And in general, the terminology pretty consistently is potentially inappropriate, because it's hard to say, without having the patient and that person's medical history in front of you. In some cases, maybe you can say like, absolutely nobody ever should be on this medication. But usually you say potentially inappropriate because there are some patients who this, particular medication might actually be the right choice for them. So actually I think with the exception of buspirone, basically, I think literally every psychotropic medication is in the VAERS list of medications somewhere as potentially inappropriate. There specifically for benzos, there are like specific medical conditions as kind of like carve outs where benzos could be appropriate. So for example, like people with refractory seizure disorder, benzo might be an appropriate thing for them to be on. They say severe generalized anxiety disorder. And so how do you define severe? There are some guidelines that say, if you've had multiple trials of medications from different classes and you've had a course of psychotherapy, then maybe that you consider treatment-resistant generalized anxiety. I think like among my colleagues, in particular, specialists in treating anxiety disorders would absolutely adamantly maintain that there are some patients for whom benzos are appropriate even as they're older. And here's where you kind of have to take the risk for that individual person, their risk factors into account. So in general, benzos, the concern for older adults is generally the most evidence is around fall risk and fall related injury. So you want to take the risk of the benzo in context of what other risk factors that older adult might have. Do they have impaired vision? Do they have chronic diabetes and they have sensory impairment and nerve damage in their feet? And so maybe they're already at elevated risk of a fall because they don't have good sensation in their feet. Are they on other kinds of medications that are already increasing their risk of fall injury? So I think the decision making, this is why working with older adults is really fascinating, is because you can have an 85-year-old who's like literally running marathons, and then you can have 85-year-olds who are super ill and have all kinds of medical problems. And so you have to really kind of individualize the risk benefit, and whether for this patient in particular, a benzo is an appropriate treatment for them or not.
Mm-hmm. And then, so does that really play into that scenario where you were talking about that sort of middle adult group that the trend is going up for prescribing, but you have no way of knowing if those people are going to be frail or super sick elderly people?
Yeah,
they're already on the medication. And so
yeah, so that's a great point. There's a saying like begin with the end in mind, and so I think that is a really important part of the conversation between clinicians and patients when you are considering starting a benzo. Is are you are you anticipating this to be a long-term treatment? Is this a short-term treatment? Are you and the patient on the same page about what the expectations are here? So another group wrote a paper where they sort of looked at trends in benzo use overall and found that in general, kind of new starts weren't really going up, but what they did see increasing was continuation. And so when I think about benzos and sort of reducing benzo use, it's really kind of two separate things. It's reducing new starts, and then it's reducing conversions from new starts to long-term users. And it's that like, you don't want to start somebody on a benzo and then just sort of like have them become a long-term user, like if that wasn't your original intent and plan. And that's where that, in this middle-aged group of users, how you don't know how many of those are going to go on to become long-term users. And you're exactly right that kind of the risk benefit for somebody who starts a benzo when they're 45 or 50 is very different from what it will be when they're 70 or 75. And like, you don't want to create a long-term benzo user by accident because you just started them on it and then you just keep refilling it. And all of a sudden they're like in their mid 70s and suddenly at risk from this medication that they were never intended to be on for like 30 years.
Yeah. And another thing too that I think about, I serve on the medical advisory board of Benzo Info Coalition. It's a nonprofit about, some of the risks and harms of benzodiazepines. And we get emails all the time from elderly folks who, and sometimes they're doctors or clinicians too, where it becomes this question of like, is this person even too frail to be withdrawn from benzodiazepines? Is withdrawal too big of a risk to put them through? What do you think about considering something like that?
Yeah, I mean, I think the goal would be that someone, if someone is so frail where you're concerned about them tolerating stopping the benzo, that's like that seems like a failure that they got to that point. I guess that I think the other thing to keep in mind is I think that there are some real contradictory there's contradictory information out there about what it's like to stop a benzo. And for some people, and some studies, like it's no problem at all.
Mhm.
And then there are other people who experience it really as like it's horrific what the process is like. And that, to be honest, in some ways that creates like a real kind of a messaging challenge when you're trying to reach out to people and engage them and get them to stop their benzo. On one hand, you want to reassure them that it will be okay and they can come off it, and there are plenty of people who have come off it and done fine. And at the same time, there are also like horror stories out there. And so the messaging, I think, around it just can be really very challenging, and our difficulty of like predicting who will have a really difficult experience and who won't. It makes it uh, challenging and interesting space, a space where we still have a lot to learn to figure out.
Yeah. Okay. So a lot of your work looks at inappropriate medical care for somebody with dementia. Can you maybe give us an example of what inappropriate medical care looks like?
Yeah, so that's a great question, and it's one where I think some uh, colleague I work with doesn't like that inappropriate. Um, I think a better way of saying it is I think caring for patients with dementia. So people really think about dementia as a disorder of memory, which is true. Um, but it also, there's this set of symptoms we call behavioral and psychological symptoms of dementia, including things like apathy, sort of withdrawal, um, sleep wake cycle disturbances, irritability, wandering, vocalization, all these behaviors that can go along with dementia that I think a lot of times family members aren't really prepared or educated about this part of the illness. And I think, frankly, a lot of clinicians don't really aren't also aren't prepared and educated about this part of the illness. And so I think to some extent, sort of in the US, because I think we don't have, say, the greatest sort of like public health infrastructure. I think a lot of times we're sort of where people turn to for help is the medical system and hospitals, and you go to the emergency room, even though a lot of times for these patients, there's not like a medical illness. Like it's not that their diabetes is um, uh, exacerbated, or their heart failure, they've decompensated, or they have pneumonia. Sometimes there are underlying medical problems that are like exacerbating these symptoms, um, but oftentimes not. Like you want to rule those kinds of contributing factors out, but a lot of times they're not there, and it's simply a manifestation of the dementia. Um, and I think a lot of times uh, family members are not really equipped to care with what can really be very challenging behaviors. And so sometimes then I think when a family and a person with dementia like that interact with the healthcare system, they can sort of get care, receive care, get uh, imaging, get urinalysis. They're in the emergency room and they're agitated and they get medication. It just, I think, can be a very like unproductive interaction between the person with dementia and the healthcare system. And so that I think really is the concern. So we did a paper where essentially it was a nationally representative survey where they did actually in-person assessments of persons with dementia. It included like the severity of the dementia, whether or not they had behavioral symptoms, and a lot of these like scales of behavioral symptoms actually include an item that says like, okay, is the person experiencing hallucinations? And it gets the frequency and severity of the hallucinations. And then it also asks the caregiver, how distressing do you find this symptom that the patient is experiencing? And so we had a paper where we basically could look at the healthcare costs and use of patients with dementia. And my kind of hypothesis was that I thought that patients who had more symptoms, we specifically looked at agitation, and psychosis, delusions and hallucination. I thought patients who had more of those kind of symptoms would have more healthcare use, more ED visits, higher costs. And it actually turned out that it wasn't the symptoms of the patient, it was the amount of distress that the caregiver reported about those symptoms that is what was associated with higher costs and higher use. And so I think that really is the bigger picture idea of, I think a lot of times in general, like the kind of the healthcare system isn't equipped to provide family members and caregivers with the kinds of sort of psychosocial help and care and supports that in fact is what they need. And instead they interact with a healthcare system that is set up to provide healthcare. And so that's kind of what I mean about potentially inappropriate care.
Yeah. Okay. That makes a lot of sense. So I think a lot of people are going to want to know this, and I want to know myself too, having taken benzodiazepines and antipsychotics inappropriately myself. Is there any research about those two drugs and maybe the Z drugs or sleeping pills on, do they actually cause dementia?
Yeah, so that's a great question. So for for benzos and Z drugs, there were a couple papers that came out initially that did seem to suggest that there was an association between use of those medications and dementia. I'd say more recent work has now suggested that that's probably not the case. And what's really tricky with any of these studies is that, so that like the gold standard kind of study would be a randomized controlled trial where you have one group of patients that don't get benzos and one group of patients that get benzos, and then you follow them for a long time and see who gets dementia and who doesn't. Obviously, no one's going to do a trial like that to follow people and see if a medication causes them to get dementia. And so what's tricky is like the kinds of patients whose clinicians are prescribing them a benzo are potentially different than the kinds of patients whose clinicians are not prescribing them a benzo. And so it just makes these studies tricky and helps explain why you can kind of get some contradictory results depending on how you do this kind of study. But again, in general, the more recent results, I think, done sort of the best way that you can do these kinds of studies don't suggest that benzos are associated with dementia. Antipsychotics, I think it's fair to say also there's not good evidence or strong evidence that they increase the risk of dementia. Where there is actually reasonable evidence, I would say, is specifically of anticholinergic medications. So the most common example people might be familiar with would be like Benadryl or diphenhydramine, which you can get over the counter. And this kind of conceptually makes sense a little bit because we know with Alzheimer's dementia specifically, you lose neurons that essentially make acetylcholine, and Aricept or donepezil, one of the treatments, I say it in air quotes because it's not a great treatment, but one of the only FDA approved treatments is a cholinesterase inhibitor. So it's basically boosting the amount of acetylcholine in your brain. So it kind of makes sense that anticholinergic medication, so blocking acetylcholine, is potentially not good for your brain health. And so it seems like, in particular, long-term exposure to anticholinergic medication potentially increases your risk of dementia. So I'm not saying like if you have like bad hay fever or something and you take Benadryl for a couple days, like that's not increasing your risk. But if you take like Benadryl every night for sleep, that kind of thing, and you do it for years, that's not a great idea. And so the reason I brought that up after talking about antipsychotics is because a lot of different medications have anticholinergic activity as part of them. So a number of antipsychotics are also anticholinergic. Some antidepressants, in particular Paxil or paroxetine, is more anticholinergic. Some of the older tricyclic antidepressants, so your amitriptyline, is anticholinergic. And then finally, so for example, my dad is a fan, until I think he stopped because I asked him to, of Tylenol PM. So all that is Tylenol, acetaminophen, plus Benadryl, diphenhydramine. So taking Tylenol PM every night for bed is not a great idea. So that's where, so maybe antipsychotics as a group, I would say probably don't increase your risk of dementia, but specifically anticholinergic meds, I think there is fair evidence that long-term consistent exposure does increase your risk of dementia.
Okay. Now, so we have an answer from you about causation, I guess, of dementia, but what about mimicking dementia if somebody's on psychotropic medications?
Yeah, so that's a great question. And I think it's one of the kind of most interesting things, in particular for older adults. So I actually have a colleague who was saying that his mom had been on Xanax for years and years and years. And I think he said it was her doctor who actually suggested that she get off. And they were super concerned about how she was going to do. And she ended up doing great and was brighter and clearer. And so it's absolutely true that we know. So here's how I describe it. Benzos get used for procedural sedation. You get them. So if you're having a colonoscopy or something else done, so you don't remember having had the procedure, they are used for short-term memory impairment. So all benzos, any benzo will have some amount of short-term impairment on cognition. I think the trick is, like, if you talk to a 70-year-old who's been on a benzo for decades, they're probably going to say, no, it doesn't do anything like that to me. But that's because they don't know what they would be thinking if they didn't have the benzo that they've been taking for decades. Um, so I think it is fair to say that absolutely benzos do cause at least some amount of cognitive impairment just as a short-term effect. And kind of the only way to really know um, how significant it is to not be on the benzo
Okay.
anymore.
So, if, we're not worried about benzodiazepines maybe causing dementia, but we're just looking at psychiatric drugs in general and older populations, what are some risks aside from dementia that, people need to be aware of? I'm elderly and, my doctor's prescribing me this medication. What else
Yeah.
could potentially be dangerous about it?
Yeah, so I think in some ways the first and most important point to make is that like every medication has side effects associated with it. Like if you look at the insert that comes with the drug, like they all have all kinds of side effects reported with them. The benefit of the medication, you only benefit if you have the condition that the medication is supposed to help. And so I don't have depression. So if I take sertraline, I don't have depression. So it can't help me with depression. On the other hand, I can experience all of the side effects from sertraline. So I think that's the first point to make, is that it really seems like there's a lot of psych medication prescribing that goes on for people who sort of don't have the actual condition, like the disorder in the way that I would think about it. And so those people kind of by definition then are only being exposed to the risks of the prescription medication. And so for SSRIs, so your things like your Zoloft, your Paxil, your Prozac, your Lexapro, those are absolutely safer than the tricyclic antidepressants that they replaced. However, they still all have risks associated with them. It could be like dizziness, lightheadedness. And, I tell my like medical students that I work with, like they might not see, if you're like 20 years old, the risk of a fall doesn't really seem like a big deal to you. But if you're like 75 or 80 and you fall and break your hip, there's like significant morbidity and mortality associated with a fall for older adults. So increasing your fall risk is not trivial. There's the risk of hyponatremia, meaning your sodium level in your blood gets too low, which again, it's like a relatively small risk. But if you have like millions of older adults being prescribed antidepressants who don't have depression, that ends up being like thousands of people who are at risk for hyponatremia. And so there was a good illustration of this. There was this clinical case column in JAMA Internal Medicine where they presented a case of a woman who basically had a family member die, was a couple weeks after it happened, was prescribed an antidepressant. A couple weeks later, presented to the emergency room because she was delirious, and turns out that she was hyponatremic. And when the psychiatry team, she was hospitalized, psychiatry team saw her, spoke to a family member, and they basically were like, was a normal, appropriate grief reaction after somebody died. And so again, this is a case where she wasn't going to benefit from the antidepressant, and yet she was the 0.01% or 0.1% who developed hyponatremia. So tiny risks, but multiplied by millions of people getting the medications, end up being like people who are harmed. Pretty much all the psychotropics have an increase of fall related injury. Yeah. And then, again, the more anticholinergic meds, you have some of the cognitive effects of that. So really, like, we know all medications have side effects. And when they're being widely prescribed, that means like a lot of people who are potentially being exposed to these risks.
Yeah. Okay, so one of the big problems we see is polypharmacy. And there was a study I saw, 1 in 7 with dementia who live outside of a nursing home are taking at least 3 drugs that act on the brain and nervous system. Do we even know the risk of this kind of polypharmacy? Like, have we studied all of these drugs in combination in elderly populations, let
Yeah,
alone younger people too, you know?
yeah. So this is like a pet topic of mine. So, one of the things from the medicating normal movie, it seemed like a theme was sort of accumulation of medications, um, which has always been a little bit of a pet peeve of accumulation of medications where particular combinations, there's just like not really great evidence that they work necessarily, particularly in older adults, and particularly in older adults with dementia. There's actually little evidence that really even any of these classes by themselves are helpful. So for example, antidepressants, there was just a review that came out, like a meta-analysis, meaning they combined a bunch of studies looking specifically at antidepressants in dementia. And there just really isn't consistent evidence that they are helpful. And that kind of is not that surprising. So depression as it is really is it's essentially a combination or a cluster of symptoms. And if you kind of have this cluster of symptoms, we think about it as this major depressive disorder or syndrome. But I think the truth is probably the underlying, say, brain chemistry or underlying etiology of those symptoms is different for different people. And so it's not surprising that if you have dementia, a neurodegenerative process that is changing your brain, that depression is a different depression than somebody in their mid 30s or mid 40s who gets depression. So it's not surprising that the medications maybe don't work the same way or as well in an older adult. Not to say that this isn't distressing. In particular, I think it can be distressing for family members. So speaking from my own family's experience with a grandfather with dementia who had uh, seemed to sort of withdraw and appear apathetic, and a family member really thought this person would benefit from depression. And so I think part of it is like family members around these folks, it seems like they're unhappy and not doing well, and they really want to try to help them. And we're kind of as a society, I think, used to reaching to antidepressants to help people. But bottom line is, for folks with dementia, they're not helpful. So then then you're adding additional medications on top of it. There's just not great evidence that these medicines, even by themselves, are helpful. Adding them on is can't possibly be good in a brain that is experiencing a degenerative illness. And then I think the other trick is that, so with antidepressants, you might experience some nausea or some increased restlessness as a side effect of that medication. So I worry that because the patient with dementia maybe can't articulate that side effect, they get perceived as being more agitated. And so then they get prescribed another medication on top of the antidepressant to treat the agitation, which is really a side effect of the antidepressant. And so that's the other concern to me of these combinations in older adults with dementia is really lack of any kind of high quality evidence for efficacy of these combinations, the potential that side effects are getting interpreted as symptoms in need of more medication or higher doses of medication that they're already on, the person's inability to articulate that they're experiencing these side effects. And then, fall related injury would be a big risk in these frail older adults. And so I just think that there's lots of problems around these kinds of combinations. And then that's not even getting into the, we know that opioids combined with other kinds of medications increases your risk of mortality. Antipsychotics, specifically in dementia, increase your risk of mortality. So then there's not only fall related injury, but actual death as an increased side effect from some of these combinations.
Wow. And just as standard, right? Elderly people do not metabolize drugs as efficiently as their younger counterparts. Is that correct?
So it definitely, I would say it depends. So one of the biggest issues is the potential, essentially the potential for altered metabolism of the medications, because of another medication you're taking might influence how your liver is breaking down these medications. So just the more meds you add on, and we know in general, older adults are on more medications than younger adults, that means you have more substances that the liver is trying to deal with. And some of these might mean the drug gets consumed faster, or it might mean that the drug hangs around longer. There are ways that the sort of body composition and the fat, essentially changes in the body composition can change the way that the drugs get distributed. So there's a variety of reasons that you need to be a little bit more mindful of how you prescribe medications to older adults. So usually sort of this idea of start low and go slow is a standard rule of thumb for prescribing for older adults.
Yeah. So I read an article that you were part of as an expert, and it was pretty disturbing to me. I didn't know this, but that the federal government essentially is sort of keeping a tally on people in nursing homes who are getting antipsychotics. But I guess then we're not getting statistics on the people who are at home getting medications, just on the ones in nursing homes. But the article was talking about how, people are being given phony diagnoses to sort of cover up the true rate of antipsychotic use, or people are being given other drugs to avoid antipsychotics. So it doesn't look like the prescribing is out of hand in a certain nursing home, but they're really just getting something else. Can you talk a little bit about that?
Yeah, I think I guess the first point that I would make is I think that nursing homes have an incredibly difficult job that they're trying to do. And also something I think people don't necessarily know is there's actually nursing homes are an important setting of care for adults with serious mental illness. So when psychiatric hospitals were closed in the 50s and 60s, and there was this big deinstitutionalization movement that happened. Sadly, the kind of promised community services and supports never materialized. And so bottom line is nursing homes became an important setting of care for patients with mental illness, not with dementia, but with schizophrenia, bipolar disorder. And so the challenge of looking at antipsychotic use, which is really, again, the safety risks are really around patients with dementia specifically, is that you also have the nursing home as an important setting for patients without dementia, but who have serious mental illness, who should be on antipsychotics, where it's clinically appropriate for them. And again, I would add that for some patients with dementia, they're also clinically appropriate. And so this is where that how do you set up a policy to get to the sweet spot of what's the right amount of antipsychotic use for the nursing home population? And so one of the ways they tried to do this is usually for any kind of a measure, if you're looking at the amount of antipsychotic use in a nursing home, there are some people you want to exclude from the measure. And so in the quality measure that Medicare uses, they specifically exclude patients with schizophrenia, patients with Huntington disease, and Tourette's syndrome. So those are kind of the three things. So patients with those diagnoses are excluded. So when you look at the amount of antipsychotic use in a nursing home, you kind of have removed those group of patients for whom it is potentially appropriate. The problem with that, again, is so bipolar disorder is not included in that group. And that's a group, for whom antipsychotics are FDA approved and can be a really important part of their treatment. And then also, frankly, like for major depression, there are some people that antipsychotics, some have been FDA approved as kind of add-ons to treat major depression. And so your psychiatrist would say there are some additional conditions for whom antipsychotic use is appropriate, and you're actually doing those patients potential harm by essentially penalizing nursing facilities for using antipsychotics in those patients. And so what happens potentially is to justify use of antipsychotics in some patients, anecdotally, patients are getting labeled with a diagnosis of schizophrenia because this removes those patients from the quality measure. And so the concern is that if you were a nursing facility that wanted to kind of game the measure, you would label more patients with those exclusionary diagnoses in order to get them out of the measure. Again, it's incredibly challenging because psychiatrists who work in nursing home settings, like this just drives people wild because they feel like they have patients who really need an antipsychotic and it's the right thing to do for them. And they get just enormous pushback from facilities that they don't want them to use these medications. Patients in a hospital on an antipsychotic who need to be discharged into a nursing home, it can make finding them a bed in a nursing facility difficult because the facility doesn't want to accept the patient on antipsychotics. And then the other concern that I've done some work on is this issue of sort of substituting other medications. So for better or worse, the best evidence we have for treating things like aggression or psychosis in patients with dementia are antipsychotics. But that's the only thing that is being measured. And so people say potentially are getting substituted and put on Depakote or valproic acid instead. And there's like very clear evidence that that medication doesn't work for people. It doesn't treat the symptoms and it has significant side effects. And so that's kind of the worst outcome, is a patient who really should be on an antipsychotic isn't getting it because of this policy pressure. And instead they're getting put on Depakote, which is as bad, if not worse, and has no evidence of benefit. Or people are getting put on these combinations of medications, not an antipsychotic, but other combinations of psychotropic medications. And so, like, bottom line is, it's just an incredibly complicated situation. I think the policymakers have had the best of intentions, but I'm just concerned about some of the unanticipated consequences that are happening and the real potential for some harms to be happening for patients because of just like this single-minded focus on antipsychotics.
Yeah. Okay. So this is kind of a loaded question, but since you're, in this world and you do all this research and you see this every day, I guess, like you said, all of this is so incredibly complicated. A lot of times it comes down to the amount of distress of the family. I mean, it sounds like, a lot of people need education maybe as you're moving towards having older parents and that kind of thing. So like in an ideal world, what do you think is the answer to this issue with maybe psychotropics and overprescription for the elderly? And then obviously, because we don't live in an ideal world, like I'm thinking for someone like myself, my dad is 70 years old now, and he luckily is doing fine mentally, but what could I do down the line to protect him as he ages from maybe some of these more dangerous outcomes in older folks?
Yeah, I think uh let's see. So I think an important part is just helping families understand that dementia is much more than just an impairment of memory.
Mhm.
And there are lots of different symptoms that can go along with it. I think a really important part of that education is helping people, really both family and say staff in a nursing facility type of setting, to know, to help them understand to not take it personally. So sometimes I think in families, um, it can, it's almost as if, um, sometimes people can get sort of mad at the person with dementia and think that they're doing it like intentionally, or they're doing it to like bother them.
Yeah.
And like they're not, their brain just isn't working the way that it used to. And so to um help uh help let go of that and not take it personally. I think an important thing that some colleagues will talk about is like relaxing the rules. And so sometimes, frequently, like something like bathing can be a real point of contention. And so maybe it's like once a week, and it's like a sponge bath instead of like fighting in the tub or the shower, that kind of thing. A patient I saw a couple years ago, um, would take dirty dishes out of the dishwasher that hadn't been run and put them back in the kitchen cabinet. And this person's very sort of fastidious spouse, that made them crazy that this person did that. And again, it's not, they're not doing it to bother you. It's like behavior that they they want to like feel like they're contributing in the household and in the kitchen. And so let them do that, and then you can just put the dishes in the dishwasher and run a load later.
Mhm.
um uh uh Patient that I saw in the clinic who came in for being sad and depressed, the referral was patient sad and depressed. I talked to the family and got the details of what was going on, and basically this person would ask their partner something, partner would answer. A couple minutes later they would ask the question again, partner would answer. This would happen a couple times, and then the partner without memory impairment would get really upset and sort of blow up at the person, which then was just reminding this person of their memory impairment and making them feel bad because their spouse was upset with them, and then they would start crying. So Zoloft is not going to help fix that. It's really about like educating the family member about what's happening. um, so I think lots of education on the family side. I think on the side of clinicians, um, we just like you can see it in like antibiotic prescribing for upper respiratory infection. Like we're just, clinicians are conditioned to like write a prescription to give people something, and if we don't give people something, it feels like we're not providing care. And I think helping reassure clinicians, um, that like their presence and listening and providing education maybe is in some situations, is enough, and it's important, and it's frankly safer also, to do that. And so anyways, those are a couple thoughts.
Yeah. Yeah. It's just sounds like a very difficult, incredibly multifaceted situation where there isn't like a perfect answer to fix everything right away and make
Right.
it perfect and ideal. But
Right. And we're not used to that in our healthcare setting.
yeah, gotcha. All right. Well, I'm cognizant of the time here. We've talked for an hour and I could probably sit here and ask you questions for another one, but I won't do that. I guess before we go, do you have any like closing thoughts or anything I didn't ask you about that you want to just, stress for people listening, or like resources for people, anything like that that you'd like to share?
Um, No, I think we covered a lot of ground. I think, again, just to reiterate that, I think it's just trying to find the sweet spot. And by and large, I think people really do have the best of intentions. And these, we're trying to, clinicians are trying to help folks and families in challenging situations. And it's just, again, figuring out the challenge of what's the right sweet spot that we're trying to figure out.
Yeah. I did see you have a podcast. Is that right? Is that active? Are you keeping
Oh,
it
that's
up?
true. So I'm part of a center here at Michigan called CAPRA, which is basically a dementia related group. And we, as part of that, a colleague in the School of Nursing and I have a podcast where we sort of talk about various dementia related. Usually what we do is invite somebody on and sort of talk about a paper and try to do it in a way that's accessible for folks. Last year, we actually did one where we talked with a colleague of mine who does a lot of research related to caregivers, dementia caregivers, and then as sort of the companion, we did another episode where we actually spoke to a caregiver who she had worked with. So that was fun. We're glad that she came on. So yeah, that's active. Our last episode of the second season, I think will be out in the next week or two. It's called Minding Memory.
Okay, cool. So we'll put a link to it for anybody watching in the description or the comments, and also a link to your Twitter as well, if they want to follow. Okay.
Great. Well, while Twitter still exists.
Yeah. Yeah. So thanks everybody for joining us today for this discussion. If you have not seen Medicating Normal yet, you can go to our website at medicatingnormal.com/watch to view it. If you're able and willing, support the film's outreach efforts with a donation at medicatingnormal.com/donate. We'll be back next week doing an interview with Dr. Chris Palmer. And thanks again, Dr. Maust, for joining us. It's been great chatting with you. And
My pleasure.
all right, take care.
Thanks.
Bye-bye.